Again, welcome to our webinar for people who are new to epilepsy. My name is Debbie Leone. I am the Senior Coordinator for Information Services at the Epilepsy Foundation of Minnesota. Hold on, I went too far. This webinar is provided by EFMN. We are a local nonprofit organization. Then we serve the entire state of Minnesota and eastern North Dakota. The Epilepsy Foundation of Minnesota is an affiliate of the National Epilepsy Foundation. Before we get into the meat of our webinar tonight, just a few housekeeping items. This is an hour-long webinar. We do ask that you not have too many screens open, especially things like music applications. That will just give you a much better experience. If you have anyone else in your house who's also using a different computer or device and maybe streaming, it might be a good idea to ask them to close out as well, just so that you don't have any issues keeping up with the webinar. We will be sending out certificates of attendance within 3 business days. And we are recording this webinar tonight as well. So it will be posted on our website for future viewing options. You will have the opportunity to ask questions, and I am going to wait and hold those questions until the end of the webinar to answer them, but you can ask them at any time. And in order to do that, you want to go to the little Q&A icon at the bottom of your screen, and then type your question into the box and hit submit, I believe it says. And as I believe I said, our program assistant, Mary Mavison, is here with us tonight too. You just can't see her, but she's here to make sure things go smoothly and to answer any technical questions. So you can put those into the Q&A as well, and she will try to take care of those as we go. Just to avoid any confusion, the chat has been disabled tonight. So again, I'm Debbie Leone, and in my role as Senior Coordinator for Information Services, I provide one-on-one support to all people who are affected by epilepsy. I offer information and referrals on a large range of topics related to epilepsy and seizures. I am a nonprofit professional. I am not a medical professional, so a little disclaimer here. The content of this webinar is for educational purposes only, and it's not intended as medical advice or diagnosis. All medical questions should be directed to your healthcare provider. So let's take a quick look here at what our objectives are tonight. After we've spent this hour together, we hope that you will be able to understand the basics of seizures and epilepsy, including some of the most common causes, different seizure types and classifications, and seizure response. You'll know the levels of epilepsy care that are available and what to expect during the diagnosis process. You will identify treatment options and understand some ways that epilepsy can impact everyday life beyond just the medical issues. And we hope that we'll be able to increase your awareness of EFMN's programs and services. We're going to start out tonight with a poll question just to kind of get you involved. I kind of always like to know who it is that's with us. So if you could answer this poll question regarding what is your relationship to epilepsy? And to answer, just put your cursor over the one that you're choosing and then hit the submit button. And we will be able to see your answers. Okay, it does look like everyone's voted already. So Mary, if you could end that poll and bring up the results. And it looks like half of you have epilepsy yourselves. A quarter of you have a child with epilepsy, and another quarter works with people with epilepsy. So thank you for taking care of that. Mary, you can take that down. And I appreciate knowing that because it kind of helps me to know where we're going with the presentation tonight. So let's start out talking about the difference between seizures and epilepsy, because sometimes these terms are used interchangeably by people, and there is actually a difference between the two. A seizure is an abnormal discharge of electrical activity within the brain. And a seizure is defined as a finite event. It has a beginning and an end. And it can be a symptom of epilepsy, but a one-time or a non-recurring event is not diagnosed as epilepsy. A seizure causes temporary changes in how a person moves, feels, or thinks. And where in the brain the seizure occurs is what determines what the seizure looks like or feels like. If the seizure is occurring in a part of the brain that affects hearing, the seizure may present as as hearing things that aren't there, which people don't always realize. That people have a stereotypical view of what seizures look like. But again, it all depends on where in the brain it's happening. It can also, if it's happening in a part of the brain that affects vision, then there may be vision disturbances as well. Disturbances to balance, speech, all of those, just general awareness. So again, where in the brain the seizure happens is what determines what it looks like, and that will be different for different people. 1 in 10 people will have a seizure in their lifetime. That doesn't mean they all necessarily have epilepsy. As I said, there are seizures that are not related to epilepsy. And some examples of those are things like diabetic seizures, where someone has excessive insulin or low blood sugar, and those are a medical emergency. Febrile seizures are seizures that are fairly common among children who have high fevers. And withdrawal seizures can happen if someone is withdrawing from alcohol or other drugs. So those are just a few of the non-epileptic type of seizures. Epilepsy, so a seizure is an event. Epilepsy is a condition. It's a neurological condition that causes people to have recurring seizures. It's typically diagnosed after 2 or more unprovoked seizures. And when we talk, there's a couple of, well, there's several keywords in this statement. One is neurological. That means that it's happening in the brain. It's not caused by some outside factor. If it was an outside factor, it would be called a provoked seizure. If it's happening just because something's going wrong in the brain, then it's a neurological unprovoked seizure. And then the second key word is recurring. As I said before, a one-time seizure is not necessarily going to result in an epilepsy diagnosis. It typically will be diagnosed after 2 or more unprovoked seizures. And again, unprovoked, it's not caused by one of those outside factors like diabetes, dehydration, alcohol withdrawal, things like that. Sometimes you will hear this epilepsy referred to as a seizure disorder. We do prefer using the word epilepsy. Most times they refer to the same thing, but seizure disorders is just much more vague. And some people use it to refer to other problems as well. So we like to use the term epilepsy. And 1 in 26 people will develop epilepsy in their lifetime. It's much more common than most people are actually aware of. So let's look at some of the causes of epilepsy. Well, basically anything that can damage the brain tissue can cause epilepsy. And so these are some of the more common causes and known causes. There may be problems in brain development prior to birth. There may be problems during birth, such as an injury or an injury to the brain or lack of oxygen. Having a neurological infection like meningitis or encephalitis, brain abscesses, inherited diseases can sometimes cause epilepsy, things like tuberous sclerosis, neurofibromatosis, which is the growth of tumors or cysts. Brain trauma, especially a penetrating brain injury, is a fairly common cause of seizures. Epilepsy is very common in people who've had traumatic brain injuries. Strokes, hemorrhage, bleeding around the brain. Genetics can sometimes play a factor. In recent years, we've learned much more about genetic factors having to do with epilepsy, and especially in epilepsy syndromes that have an entire little universe of symptoms that go along with just the seizures. Many of those are genetic in nature. and result from abnormalities in the genes, some of which are hereditary and some of which are not. But really, in most cases, they don't know the cause. The cause is never found. You know, it's very easy to say it had a traumatic brain injury and ended up with epilepsy, but for some people, they will just start having seizures and be diagnosed with epilepsy, and there's nothing that has happened to them that can explain it. So let's talk about seizure types, and this can get a little confusing. There are over 40 different types of seizures. We are not going to go through every one of them tonight. We don't have time for that. But we have the seizure types and classifications have been changed in recent years. In the past, you may have heard of things like simple partial seizures or complex partial seizures or grand mal or petit mal. And there are some people who still use those terms. And in fact, there are still some doctors who use those terms, but they've really been changed in recent years in order to focus on just to better describe where in the brain the seizure begins and also what the seizures look like. So what we have now are divided into two major types, the focal onset seizures. And focal just means it's coming from a specific area within the brain, that the seizure begins in a specific isolated part of the brain. And again, depending on where that location is, the person having the seizure may be totally aware, but they just can't control what's happening. So in those cases, that would be a focal onset aware seizure. And in those cases, they may experience something like uncontrolled jerking of their muscles, maybe one arm or hand jerks, those types of sensory seizures where they hear or smell or taste something unusual, or even experiencing an intense emotion like fear or laughter. You know, it can be a simple a focal onset aware seizure. They don't lose consciousness, they don't lose awareness, they know what's going on, but they just can't control whatever part of their body is being affected by the seizure. Also, another type of focal onset seizure is an impaired awareness. These are the ones that used to be called complex partial seizures. And in these cases, they are either completely or at least partly unaware of their surroundings. They may not lose total consciousness, but they display clumsy or disoriented movements. They may walk around aimlessly, pick things up, have sort of nonsensical speech where they're talking, but they're not really saying things that make any sense. They may smack their lips or pick at their clothing or wring their hands. Those are all examples of seizures that are focal in onset. They're coming from a specific part of the brain, and they impair the awareness of the person having it. In a generalized onset seizure, that is a seizure that begins across the entire brain. And it affects the entire brain, and because of that, the seizures will cause a lack of awareness. There are different ways they can present. The one that you see all the time in the movies and on TV, because it's the most dramatic type of seizure, is a generalized tonic-clonic seizure. These are the ones that were formerly called grand mal seizures. And this is where the body stiffens and then shakes uncontrollably. The person, if they're standing, they will fall down, they'll lose consciousness. Then there's another type of generalized onset seizure, again, affecting the entire brain, but this is called an absence seizure. And these were formerly called petit mal seizures. And these are characterized by just brief staring spells. And when I say brief, sometimes they last just seconds at a time. But a person having them might have 100 over the course of the day. And during that time that they're having those brief staring spells and that brief lack of awareness, they don't know what's going on around them. So you can see how that would be a real issue, a real problem for people in a work environment or a school environment when you're trying to work or you're trying to learn, and every couple of minutes you're just kind of losing awareness of what's going on. And those, as I said, they're brief, and the person tends to come back from it pretty quickly, almost instantaneously. With a generalized tonic-clonic seizure, there's usually a recovery period that happens with that, and that can take, it can be minutes, it can be hours. So again, epilepsy is highly individualized, and the seizures aren't going to look the same in any two people. Now, it is typical that when someone starts having seizures, once they've established having seizures, that individual will tend to have the same type of seizures over and over again, as opposed to switching back and forth. But it is possible for one person to have multiple types of seizures as well. So let's talk a little bit about how to respond to a seizure. And it really, different types of seizures do require different responses. And it's really beyond the scope of this 1-hour webinar to really discuss seizure response in general, or in great detail according to the different types. But here are just some general guidelines to remember. The first and most important one is most seizures are not medical emergencies. They can be very frightening looking, but in most cases they are not medical emergencies. So the most important thing to do is to time the seizure, because if a seizure lasts 5 or more minutes, that is the point at where it is considered a medical emergency and you want to call 911. The most important things to do while you're timing is just make sure the person is safe from injury, make sure there's not broken glass around that they've fallen into. It can help to loosen any tight clothing, like a necktie or something that's tight around their neck. Take off their glasses, turn them on their side if you can, so that they don't, any saliva will run out of their mouth. Don't put anything in their mouth. That is really important. There was an old wives' tale that said you should put a ruler or a wallet or just something in a person's mouth to keep them from swallowing their tongue. It's not possible to swallow your tongue, and it can actually cause more trouble than it could prevent, because putting something in their mouth could result in a choking hazard. And if you're the person trying to put something in their mouth, you also may get bitten when they are having one of those severe contractions. So yeah, you don't want to do that. The only exception would be rescue medications, if that's applicable. And we're going to talk about rescue medications a little bit later here. Never hold down or restrain a person having a seizure. If someone is having a focal seizure with lack of awareness and they're wandering around, just gently guide them away from danger. If they look like they're walking toward the street, make sure that they don't, and approach them from behind. Don't grab hold of them, because they could be in a fight or flight response at that point, and you don't want that. Just gently guide them, keep them safe, stay with them until the seizure ends. And if it's a seizure that has a recovery period, stay with them until they are able to let you know that it's okay, and that they're back and that they're able to function again. And again, call 911 if the seizure lasts more than 5 minutes. Call 911 if they have a seizure and they don't fully recover and then another one happens. Seizures that happen one right after the other are also considered medical emergencies, even if they're not lasting that long. If you want to know more about how to respond to different types of seizures in more detail, you can contact EFMN to learn more about our seizure recognition and response trainings. Okay, so let's say you're an individual who's had their first seizure, your child has had a first seizure. And in all likelihood, maybe you went to the emergency room. If you had never seen this before and were scared, you may have just been noticing behavior that's unusual. So, you've made an appointment with your doctor. So what are the first steps to go through? The first is really to assess the level of care needed, okay? If you went to the emergency room, if you were, again, just saw something that you didn't think was right, but you weren't sure if it was a seizure, then your primary care physician may be the first place that you end up. Really, the type of doctor you see first is going to depend on the severity of your symptoms and your individual circumstances. So we can't ever say everybody should go to this type of doctor. next level of care is a neurologist. And this is where most people who have epilepsy are receiving their care, is from a general neurologist. This is a doctor who they specialize in treating diseases of the brain and the central nervous system. And that includes epilepsy, among other things like stroke and Alzheimer's and various other neurological conditions. If you've had a seizure, first seizure that's required a trip to the emergency room, or if you've gone to your primary care physician and they suspect that it might be epilepsy, you will probably be referred to a neurologist. The next level of care is an epileptologist. And in most cases, this is really recommended for more difficult to treat cases. This is a neurologist, so they're already a specialist, but then they have additional specialized training or certification in treating epilepsy specifically. They often work in a comprehensive epilepsy center, although there are some epileptologists that do work in general neurology clinics as well. A comprehensive epilepsy center is really the highest level of care for an individual with epilepsy. And this is really recommended. Actually, an epileptologist and comprehensive epilepsy center, they kind of go together in terms of when they're recommended. If they treat epilepsy specifically, I mean, that's their focus in a comprehensive epilepsy center. But then they also treat related conditions, and we'll talk a little bit later about some of the conditions that can be related to epilepsy, but they provide a multidisciplinary approach to treatment. So not only will they have epileptologists on staff, they may have psychologists, neuropsychologists, neurosurgeons, social workers, and specialized nursing staff, and they all work together to provide that comprehensive treatment. A comprehensive epilepsy center will be able to offer more advanced testing and treatment options that may not be available at a general neurology clinic. So if an individual has been seeing a neurologist and has been unable to get their seizures under control, and they've tried multiple medications and they've been at this for a year or more and nothing is working, then we definitely would say it's time to seek help at a comprehensive epilepsy center. They are also a good place for people to go who also have co-occurring conditions, things like autism, women who are pregnant and have epilepsy, just because they are more specialized and better able to deal with those co-occurring conditions. So let's talk now about how to get ready for that first doctor visit. If you've been referred by a primary care physician or an emergency department doctor, it may take several weeks before you're able to get in to see a neurologist. So what can you do what should you be doing in the meantime until you can get in to see a neurologist or an epileptologist? Well, if you continue to have seizures during that time, be sure to keep a seizure diary and track those seizures. And it doesn't have to be anything fancy. It can be a small notebook. There are apps out there on the market that you can get for your phone that you can use to help track your seizures. But the important thing is to make sure you're tracking them. You want to track the frequency, the time of day they're happening, what happened right before, what happened during the seizure, what happened after the seizure. Now, obviously, if you're the person having the seizure, you aren't going to know what happened during it. But if somebody witnessed it, ask them to really say what it is they saw and to be very specific. If someone says, your right hand was doing this, that can be important. So you get as much detail as you possibly can about what's happening during your seizures, and also, again, how often are they happening? What time of day? Do they always happen at night? Are they happening at varied times during the day? All of that information is going to be able to help your doctor make a better diagnosis and guide his or her treatment decisions and recommendations. Very seldom does a seizure occur in the doctor's office. So in order to make a diagnosis and to recommend treatment, the doctor really has to go on what they can see in a clinical exam and in tests, which we'll talk about in a few minutes here, but also really they rely heavily on that medical history they're getting from the patient themselves. So it's important to try to come in with as much information as you can. If you're having seizures before you get to see your doctor, see as you're tracking them, try to see if you can find any patterns in what might be triggering the seizures. There are different people have different seizure triggers. And we'll talk more about that later, but is it that every time you didn't get a full 8 hours of sleep, you have a seizure? Or is it that you just got busy and didn't drink anything all day and you were dehydrated? Try to establish it, and not everyone's going to have triggers. So don't get too frustrated if you are paying really close attention and you can't see a pattern, because not everyone has specific triggers, but try to see if you can find those. And then take that seizure diary and all that information that you've written down and take it with you to your doctor's visit, so that when he asks you questions, you don't have to rely on your memory or on the memory of the people who maybe witnessed it but couldn't come to the doctor with you. Especially right now during this COVID epidemic, when we're sometimes limited on who can be there with us in the doctor's office. You want to have as much written down so that you can share it with some confidence and know that you're giving the doctor good information. And write down your questions as well, because it's very easy. Doctors are very busy, and it's very easy to get through an entire visit and then come out thinking, oh, I wanted to ask him about this one thing and I forgot. Write them down and write your most important questions. Write them in order of importance, because you may not get to all your questions. So what can you expect during this initial diagnosis visit? Well, the first thing is a complete medical history is going to be taken. That can help to determine whether there may have been a past injury or an illness that could have caused damage to the brain. It can also help to rule out, especially if you're seeing a primary care physician, but even if you haven't, if you're going to a neurologist, there are some things that, some conditions that mimic seizure activity. And so they're going to take a complete medical history to try to get a handle on what it is that might be causing this seizure activity. They're going to do a physical exam, and that's going to help determine if there may be other conditions that may be contributing to your seizures. It's really important for your doctor to know if you're being treated for other conditions already, because especially if you're on medications, because that could affect the medications that your doctor's going to be able to prescribe for you. The doctor's also going to want to know, again, as much detail as possible about what was happening during those seizures. So pull out that seizure diary and let them know. They'll do a neurological exam, and during that they're going to assess your muscles, your senses, your reflexes, your mental functions as well. So let's talk about testing, because you've been through the exam now. So what tests are they going to run? It can vary from one person to another, from one doctor to another. And again, the tests that they are going to want to run are going to depend greatly on that medical history and what they've learned about you so far. But some of the most common ones, the most common one I would say is the EEG, the electroencephalogram. And what this does is it measures the electrical pattern of brain activity. Remember, we said when a seizure is happening, it's happening because there's abnormal activity in the brain. So they're going to do an EEG to see if they can detect that. Now, some EEG, and again, as I said, you're probably not going to have a seizure in the doctor's office. You probably won't have it during the EEG. So it may not show anything. And that does not necessarily mean you don't have epilepsy. Some seizure types just aren't going to show up unless the seizure is actually happening. But there are some seizures specific seizure types that are associated with specific EEG patterns, even when there's not an active seizure happening. So the doctor's going to be looking for that and trying to figure out if there's something within your brain activity that might indicate that these are epileptic seizures. They may do blood tests to check for certain medical disorders. They may do an MRI or a CT scan. And where the EEG measures the electrical pattern in your brain, the MRI or the CT scan is looking for structural problems. abnormalities, tumors, infections, things like that. And there may be certain very well-defined epilepsies that the doctor is pretty sure from your EEG, that's what you have. And if that's the case, they may skip the MRI or the CT scan. So again, it's going to be different for different people. And then the last thing, and this may not always be done, but they may recommend, and probably won't be, in all likelihood would not be done at this visit, but they may recommend that you have neuropsychological testing done. And what that does is it determines what impact, it's an array of tests they do to determine what impact the seizures might be having on things like brain development, behavior, and cognition. And especially among children, this might be recommended because their brains are still developing. And deficits in any of those areas can really contribute to problems in learning. And in that case, early intervention is really essential for the best outcome for the child. So that may be something you may be looking at for your child. So let's talk about treatment. Medications are nearly always the first line of treatment. About 70% of people will achieve seizure control through medication. There are over 30 anti-seizure medications, so if one doesn't work, there are others that can be tried, or if you have bad side effects from one, there are others that can be tried. The goal of medication is always to achieve the best possible seizure control with the least amount of side effects. The hope is that monotherapy is going to be successful. And what that just means is one medication. But often it can take multiple medications or polytherapy to be able to gain control. If you experience unpleasant side effects, it's really important to report them to your doctor. Because again, as I said, there are other medications that can be tried. Don't ever feel like you just have to live with it. They're going to weigh the risks and benefits. Especially if you've got really good seizure control with that one medication. But, you know, seizure control is important, but so is quality of life. So if the medications are causing really severe side effects, share that with the doctor and make sure that you tell them that you want to at least talk about other options. Some of the more common side effects, you know, all of these medications work on the brain. So some of the most common side effects have to do with things that are associated with the brain, things like tiredness, dizziness, memory problems. Before when your doctor prescribes that medication, ask them what side effects your medication might have. But don't necessarily be scared off by a long list of side effects. Sometimes those side effects are rare, and they have to list them legally. Other times, it may be that they're fairly common, but that doesn't mean that you will necessarily experience them. Everyone is different with these medications, just like they are with their seizures. And some people will have every side effect that medication could possibly is known to have, and others will take the exact same medication and not have any side effects at all. So just remember that when you hear people talking about such and such medication being wonderful or terrible, keep in mind that the effects are different for each person. And always remember when you're dealing with your doctor that you have the right to advocate for the best treatment options for yourself or your child with epilepsy. So the doctor's going to make recommendations based on medical reasons, but you have the right to at least, you know, raise those concerns and be listened to. Another separate type of medication that might be prescribed is an emergency or a rescue medication, or also known as an emergency medication. These are used in emergency situations to immediately stop a seizure that won't stop on its own. We talked about that 5-minute mark and how a seizure that lasts more than 5 minutes is considered a medical emergency. Well, if that 5 minutes has gone by and you have a rescue medication, you can administer that. And the idea is that if it works the way it's supposed to, it will stop that seizure. And there's a variety of emergency medications available. There seems like there's some new ones coming up all the time. And there's basically 3 different ways that that they're administered. I hesitated there for a minute because there's another way as well, but that would only typically happen in a hospital setting, and that's an injection. But for home use, away from the doctor's office or away from the medical setting, the 3 different means of administration are basically rectal, which means it's administered in the rectum and it's used a pre-dosed applicator. So these are very safe. And it's impossible to overdose someone. Obviously, it might not be the most desirable method, particularly as a child gets older due to privacy concerns, or even, concerns with when someone gets older and they're heavy, if they're in a wheelchair and you have to take them out of the wheelchair in order to administer a rectal medication, it can be a problem. But it's a very effective, one thing that makes that so effective is it gets into the bloodstream really quickly. The second method is buccal, and that means that it's administered in the region of the mouth between, oops, I hit my, hold on, there we go, back to that. It's administered in the region of the mouth between the cheek and the gum. And again, it's absorbed, it's not swallowed. It's not designed to be swallowed, especially, it's kind of hard to swallow during certain types of seizures. But it's absorbed through the mucous membranes in the mouth. And again, a pretty quick way of getting it into the bloodstream. But again, if someone's having a convulsive seizure, it can be kind of tough to administer. And the third way is nasal, and it's exactly what it sounds. It's a spray that is administered through the nostrils, and there are several new pre-dosed ones. This has been a long time coming, and it's one of the most exciting things that's happened in rescue medications within the last couple of years, is that we have at least 2 now that are pre-dosed and just can be squirted up there and don't have to be mixed with anything, don't have to be transferred from one container to another. They're very quick, they're very easy, there's no measuring involved. So again, they're always working on new medications, and that was one we were happy to see come on the market. So let's say that you're an individual who's been trying these medications and they're just not working. And you've tried multiple ones, and either the side effects are so terrible that you can't tolerate them, or they're just simply not controlling your seizures. What other treatment options are out there? Well, that's going to depend on the type of seizures and where they originate in the brain, among other things. But some of the other treatment options available, the first is surgery. And that may be, the most common one would be for them to do what's called a resection, where they just go in and they actually physically remove the part of the brain where the seizure is originating. Obviously, if someone's having a generalized seizure that affects the entire brain, that's not an option. So these are for focal seizures. These are for seizures that they are able to very clearly establish exactly where in the brain it's happening. And also they know that it's not in an area of the brain that's too deep to get to, or is too close to an area that affects major functioning. You don't want to remove it and get rid of the seizures, but then be left with not being able to see or hear or speak or function in some way. So there's a lot of testing that's done ahead of time before surgery is considered. But for people who are good candidates, it can be very effective. And once that surgery happens, and if it works, then the epilepsy is basically gone. Really is the one and only way of curing epilepsy, is through surgery. And again, not an option for everyone. Another option are devices, and these are actually devices that are, again, a form of surgery, but instead of removing something, they're actually putting something into either the brain or the neck, but they are, these are devices that are implanted, and they are designed to interrupt the process of a seizure and hopefully stop it, in some cases, stop it before it starts. So some examples of this are the vagus nerve stimulation device, which is a device that's implanted in the upper chest and attached with wires to the vagus nerve, which runs into the neck and up to the brain. And it's used along with a wand that is a magnet. And when the seizure is happening, you can swipe that wand and so to stop the seizure from happening. There's also responsive nerve stimulation and deep brain stimulation. And these are two different forms of devices that are actually implanted into the brain. And they, again, stimulate the nerves, stimulate the brain to make those seizures stop or to prevent them from happening. And in some cases, they are kind of smart devices where they actually learn the electrical activity that's happening in the brain so that they can recognize when a seizure is starting and immediately stop it. So again, not everyone's going to be a candidate, but it is an option for some people. Diet is another possible treatment option. There are special diets like the ketogenic diet or the modified Atkins diet that can be used. This is not the same as your neighbor who's gone on the ketogenic diet to lose 20 pounds. Same idea, but these diets have to be very carefully regulated by nutritionists so that they, and overseen by the doctor so that they are getting the exact specific nutrients so that they don't get sick from having not enough nutrients. And also just there has to be the right balance, the exact right balance of fat to carbohydrates to, but basically these have been successful for some people, especially children. The downside to dietary therapy is that it can be very difficult to maintain. These are very, very restrictive diets. And while some people have wonderful success with them, other people have just can't tolerate the restrictions to their diet. Can be especially hard when children are very young. It can be easier to control, but when they get older, it can be tough. So again, and then there are new therapies, things like medical cannabis, and then social and psychological support. And I put that on there because I include in that things like seizure response dogs. It's not technically a treatment option, but it is. They can help their owners to cope with seizures by notifying someone when a seizure is happening, protecting the owner from injury during a seizure, and maybe helping them to recover from a seizure a little bit more easily. And just the stress relief of owning that dog and knowing you can depend on it in case of a seizure can be helpful in reducing the stress that can cause seizures. So again, not everybody's a good candidate for these options, but for someone who's tried 2 or more anti-seizure medications, if seizures have remained uncontrolled for a year or more, they may want to explain or explore some of these options. And these are usually available at a comprehensive epilepsy center. So seizure action plans. Let's talk about this a little bit. A seizure action plan, because everyone's seizures are different, and they may require a different level of response, you're going to want to have a seizure action plan that you put together in cooperation with your doctor. And that plan is going to provide details, individualized written guidelines so that those people around you know how to respond in case of a seizure. It should say what your seizures are like, what medications you're taking, how to respond, and when for you a seizure becomes an emergency, because that can be different. You know, that 5-minute guideline is a general guide, but your doctor may decide that anything longer than 3 minutes for you is a medical emergency. So again, all the details will go on your seizure action plan. It can help you to avoid those unnecessary ambulance calls when someone doesn't know, doesn't know what's going on and thinks, oh, this looks awful, I'm going to call right away, and maybe it's not necessary. You need to keep a copy on file in the places you spend the most time. School and your place of employment are very important. And if you have a child with epilepsy, share that plan with their babysitters and other caregivers so that they are aware of what to do. We do have sample seizure action plans here at EFMN, and I am going to send out those sample plans for both adults and children with the copy of this PowerPoint and your certificate of attendance. You need to think about disclosure, and that decision is really a personal one. about who to tell, when to tell, whether to tell. But it can be an important way to ensure your safety. If people know that you have epilepsy and know what to expect and how to help you during a seizure. So you should consider at least disclosing to your employer, to your school, to your family and your friends. And some people worry that they're either going to be discriminated against or be treated differently by family and friends. So again, very personal decision. And we here at EFMN can certainly talk to individuals and help them weigh the pros and cons. It's an individual decision. Just know you don't have to disclose to everyone at once. You may just want to do it on a need-to-know basis for certain people. Oops, sorry, got ahead of myself. But you should know that employers and schools are required to maintain your confidentiality if you do disclose to them. And if you have very well-controlled epilepsy, it may not always be necessary to disclose. As long as you're taking your medications and you're staying under control, then maybe nobody else really needs to know. So let's talk about some of the areas where epilepsy can affect individuals. And I have been talking too much, and we're getting close to the end here, and I want to leave time for questions. So I'm going to go through this these last slides a little bit more quickly. From about 25 to 50% of people who have epilepsy will also be diagnosed with a psychiatric disorder. It often coexists with other neurological or psychiatric disorders. Those who have epilepsy are at higher risk of developing a psychological disorder, and those with psychological disorders are also at higher risk of developing epilepsy. It goes both ways. And there's various ideas of why. It could be disruption in brain chemistry, can be effects of the anti-seizure medication, or just, the difficulty and the stress of dealing with the life change of being diagnosed with epilepsy. For those who have, who do experience these in adults, the most common disorders that are seen are anxiety and depression. And in children, it's ADHD, depression, and anxiety. Sometimes changing your seizure medication can make a difference and alleviate some of these emotional and behavioral problems. For others, just adding an antidepressant or mental health counseling can be very helpful. Some anti-seizure medications actually act as mood stabilizers and improve mental health conditions, but something else to be aware of. All right, let's talk about driving and epilepsy, because this is one of the most common questions we get when people are first diagnosed. People with epilepsy can legally drive in Minnesota as long as they have been seizure-free for at least 3 months. And if you have a seizure, or what the state calls a loss of consciousness or voluntary control, you have to report it to the state within 30 days. And there is a special form, and if you ever need that, you can get that on you can get it directly from us by giving me a call, or it's also on the Department of Public Safety's website. You have to be seizure-free. If you lose your driving privileges because you had a seizure, you have to be seizure-free for 3 months in order to get that license reinstated, and you do have to have certification from a doctor that you are cleared to drive before they will reinstate that license. And you use the same form that you used to report. You use that same form again when you're ready to get your license back. Minnesota is a self-reporting state. That means doctors don't have to report seizures. It is your responsibility, but doctors are allowed to report if they believe that their patient has not reported and is continuing to drive. So that's really important to know. And there are some exceptions to cancellation in certain cases. If the seizure was due to something temporary, but and is unlikely to happen again. But again, that would require a doctor saying that. Let's talk a little bit about safety in epilepsy. We talked about seizure response plans and how they can help keep you safe, but safety in your environment is really important too. So think about safety around water. Drowning is a fairly common way that people with epilepsy die. Avoiding taking baths or getting into hot tubs is a good idea. Take showers instead. Hang your bathroom door so it swings out, not in, and that way it can't be blocked from opening in case there's an emergency. Don't lock the bathroom door, hang a sign on it instead to indicate it's in use. That way, if you have a seizure, someone can get in to help you. Fire safety is important. If your seizures are uncontrolled, be very, very careful around heat and flames. You know, stay back away from a campfire. Electric stoves may be safer than gas stoves due to the flames. Using a microwave is even better. Cook on the back burner. That way you're less likely to lean on the burner or spill hot food on yourself if you have a seizure while you're cooking. Set your maximum hot water temperature on your house to 110 degrees Fahrenheit so that you don't accidentally burn yourself if you have a seizure when you're using hot water. Put guards on open fireplaces, put guards around radiators. Don't smoke or use matches when you're alone. If you have a seizure and you drop that match or you drop that cigarette, you could start a fire. And when you're alone, that's a terrible situation. Just in general, safety-proof your environment. Look around your house and try to see where there could be danger if you had a seizure. Look for sharp corners on furniture, use non-slip carpet, avoid scatter rugs that are tripping hazards. And if you wander around or you're confused during or after a seizure, pay special attention to heights and railings, nearby pools or bodies of water. Keep your door shut when you're at home alone so that you don't accidentally wander outside or into dangerous areas. And make sure someone else, like a neighbor or a friend or a family member, has a key to get in and check on you if they don't hear from you. You can also fall-proof your home, you know, avoid glass coffee tables that could shatter if you fall on them, things like that. There are also seizure alert monitors that detect the motion of convulsive seizures. Those are the only type of seizures they really are effective with, but you can wear those and they will actually alert someone else if you have a seizure by sending them a text or a phone call. There's only one that's approved by the FDA as a medical device, but we have a list of all devices that are available, and we can send those to you upon your request as well. I want to spend just a minute talking about SUDEP. This is a really difficult subject to talk about, and for years, people, even doctors, avoided talking about it, but we always want to bring it up just for awareness, because there have been people affected by it who tell us later that they had never been warned of the possibility and they wish someone had told them. So SUDEP stands for sudden unexpected death in epilepsy. And it is, as it says, the sudden unexpected death of someone with epilepsy who was otherwise healthy. And in these cases, no other cause of death is found when an autopsy is done. Every year, about 1 in 1,000 adults and 1 in 4,500 children with epilepsy die from SUDEP. And it is the leading cause of death in people with uncontrolled seizures. No one is really sure why it happens. Some people think it might have something to do with an irregular heart rhythm or breathing issues. There's a lot of research still being done on it. We do know there are certain risk factors. SUDEP risk is higher in people, as I said, with uncontrolled seizures, those whose epilepsy began in childhood. Young adults between the ages of 20 or 40 years of age are at higher risk. Someone who's had epilepsy for a long time, someone who doesn't take their medications regularly as prescribed is at higher risk. And having seizures at night puts you at higher risk. Often people who die from SUDEP are found in their beds. There is the National Epilepsy Foundation actually has an institute to study and raise awareness around SUDEP, and this is the web address for that if you would like to get some more information. Keeping seizures controlled is the best thing you can do to reduce your risk of SUDEP. So taking your medications as scheduled, knowing your seizure triggers if you have them and avoiding them, avoiding excess alcohol or the use of recreational drugs, living a healthy lifestyle in general, adequate sleep, good nutrition, regular exercise, all of those things are your best bet for avoiding SUDEP. And that kind of leads us into epilepsy self-management. You know, it's really important to take an active role in your medical care. Report any changes in your seizure activity or type, your medication side effects, your mood. Don't just sit back and let your doctor do it all. You really need to take an active role. If something's going on, you need to be willing to share that and advocate for yourself. Again, learn your seizure triggers. These are some of the most common ones here: missing medication, stress, and lack of sleep, but there can be many more. They're very individualized, just like everything else having to do with epilepsy. And again, just in general, do all the things we all should be doing, practicing good self-care: diet, sleep, exercise. I do want to just very briefly talk about the programs and services we offer at EFMN, and you will be getting a copy of this PowerPoint, so you can look these over. But these are some of the things that we do offer. We have had to pivot due to COVID-19, and so many of the things that we were previously offering in person, we're now having to do via virtual. Our Connect groups are meeting virtually on Zoom. We did have to cancel our Camp Us this summer, which was that was very disappointing for us and for many of the kids who come there every year. But we are trying to offer some outdoor adventure type of things through Zoom. So again, check out some of our programs and services, look at our website, and you'll be able to find some of those. Information services, as I said, I am the coordinator for information services, and I do want to let you all know that we do offer free one-on-one support with customized tools and resources, and you can call me about just about anything related to epilepsy. If I don't have an answer, I will certainly do my best to get one for you and refer you to any resources that can help with your questions. And we also have written materials which are available for download to our website, but some of them are also available in paper form, and by contacting me, you can request those materials as well. Our general contact information for the Epilepsy Foundation. We do always accept donations to help us continue to provide the services. So I just wanted to make a mention of that as well. References to some of the things that we talked about. And then I do want to take a look and see if anyone has any questions. And I know we are pretty much near the end of our time, but okay, yeah, let me look here. So I do have a couple here. I'll try to get to real quick. One is, why would somebody get an epilepsy diagnosis if they've only had one seizure? So apparently they may have gone to a neurologist and only had one seizure, but immediately was diagnosed, even though it's supposed to be, the definition is 2 or more. That can happen if they've done an EEG and they see that there are patterns that are very specifically associated with a certain type of epilepsy, or if they see something in the tests or in your medical history that make them believe that another one is very likely, they may put you on medication right away and give you that diagnosis, even if you don't have haven't had a second seizure yet, because they, if they're pretty sure it's going to happen, they may want to get you on medication to avoid that, because the more seizures you have, the more stress is being put on your brain. So that's always a good thing to try to avoid more. Is the Empatica band dependable? Okay, that's talking about the Empatica is the company that makes the Embrace 2 wearable device that detects seizures. We are not able to make recommendations one way or the other about it. My best advice, it has been approved by the FDA. It is the only device of its kind that's been approved by the Food and Drug Administration as a medical device, and it does require a prescription. So my best advice would be to talk to your doctor to see if they know much about it, if they've had any patients who have experience with it, and really do as much research as you can. Talk to, contact the Empatica folks and really try to ask if they have data. In order to get FDA approval, they have to have done clinical testing on it. So they should be able to point you in the direction of the data that shows what the results have been of their testing. Okay, well, it does look like we have reached the end, and I don't see any more questions. So I want to thank you all for being here with us tonight. Please feel free to reach out to me with any additional questions or concerns you might have. And I want to thank you, and I hope you enjoy the rest of your evening.